Assalamu alaikum. Good day, everyone. Um Today, I would like to discuss with you a summary of NCCN COVID-19 resources for the management of breast cancer patients during the COVID-19 era. As we know that we are going through this COVID-19 pandemic crisis, and our cancer patients are really vulnerable to contract COVID-19. And when they contract COVID-19, they're at significant risk for developing severe events. Um So earlier studies from China have shown that the cancer patient, when they contract COVID-19, their mortality rates were about 6%. There was a study published in JAMA. There was another study published in Lancet, which had reported that when the cancer patient contract COVID-19, they're at significantly higher risk for severe events with COVID-19 infections, such as requirement of their admissions to ICU, invasive ventilation requirement, or the deaths. Therefore, definitely there is a need to minimize the encounters between the healthcare workers and the cancer patient. And for that reason, international medical oncology societies and their experts have provided their insights and guidance and recommendation to provide optimal care during this COVID-19 pandemic crisis. And I went through COVID-19 resources of NCCN guidelines. These are really remarkable recommendations, and there are really beautiful resources provided by NCCN guidelines in terms of recorded webinars, and there are some online webinars by American Cancer Society COVID-19 and Cancer Eco Series. They have also provided some online courses, free of cost online courses, which make us enabled to talk to patients about cancer treatment, risk factors, and treatment cessation during the COVID-19 pandemic. Other beautiful thing in the COVID-19 resources in NCCN guidelines is actually the site-specific cancer management recommendation. On the top of the list is the breast cancer, and that's the topic of my presentation. They have also provided the recommendations for supportive care as well. So NCCN guidelines and NCCN experts, like NCCN COVID-19 resources, have recommended that the cancer patients are definitely the most vulnerable patient to contract the severe COVID-19 illness. So for that reason, they have recommended that the medical oncology goals are to minimize patient interaction with the healthcare centers in order to minimize the exposure of COVID-19 to both the patients as well as the healthcare workers. And that will be able to conserve the healthcare resources as well. And for that reason, NCCN has recommended to prioritize the cancer treatment to different cancer patients, like which patient need to be seen in person, or which patient can be seen through telemedicine, or which patient we can defer the treatment for some time, and which patient we can defer the treatment for longer period of time. And for that reason, NCCN has provided three different priority categories. Priority A category includes those patients who are in immediately life-threatening condition. These are clinically unstable, and these patients need to be seen in person as soon as possible. The examples of the priority A category include patients who have potential medical oncologic emergencies. For example, febrile neutropenia patient, they need to be admitted into the hospital and receive epidural antibiotic, as the febrile neutropenia is a medical emergency. Priority B category patient include those patients who are not in life-threatening condition, who are clinically stable, and for whom we can defer the treatment for some time, for example, 6 weeks to 12 weeks, that will not impact overall outcome of these patients. However, the treatment cannot be indefinitely delayed until the pandemic is over, and that's going to jeopardize the life of these cancer. Examples include, for example, those patients who have HER2 negative breast cancer, hormone receptor positive breast cancer, receiving neoadjuvant endocrine therapy. These patients actually can wait 6 months to 12 months for the surgery, so the OR resources can be conserved. So these newly diagnosed breast cancer patients on active IV chemotherapy or patients completing neoadjuvant therapy preparing for surgery, they can wait for the surgery. So these are the examples of the priority B category. Priority C category patients are those patients who are clinically stable and for whom the treatment can be delayed indefinitely until the pandemic is over without adversely impacting the outcomes. Well, I'm not sure that how long it will take the pandemic to be over. I'm not so optimistic that the pandemic will be over within 6 months. Maybe it will take 1 year or more. So definitely NCCN's definitely mean indefinite deferment is to probably 6 months to 1 year. More than that probably would be difficult. And the examples of this group of patients include patients, those who are presenting for routine follow-up for benign or malignant conditions, including those who are on oral adjuvant agents, are those patients who have been cured, but they are being followed up for the survivorship issues. These patients can be seen remotely, or their visits can be deferred until the pandemic is over. NCCN has provided recommendations for invasive early breast cancer during COVID-19 pandemic. The first group of patients is hormone receptor positive and HER2 negative tumors. So these patients, as I said earlier, they can stay on neoadjuvant endocrine therapy for 6 months to 12 months without clinical compromise, and OR resources can be conserved. The second two groups of patients include triple negative breast cancer and HER2 positive breast cancer. These two groups of patients, the neoadjuvant chemotherapy has been the standard of care for these two groups of patients, and the neoadjuvant chemotherapy has been associated with significant improvement in pathological complete response rates in these group of patients. So first, triple negative breast cancer, NCCN recommends to use single agent sequential therapy. There was probably this recommendation is based on the earlier study, which one of the study was published in JCO 2003, where the sequential chemotherapy was compared with concurrent chemotherapy in dose dense and dose intense fashion, and both concurrent and sequential chemotherapy were equivalent. So based on that, NCCN is recommending to use single agent sequential therapy that will probably have lesser treatment complications such as febrile neutropenia and lesser number of visits to the cancer centers without compromising the efficacy. For HER2 neopositive breast cancer, NCCN has provided two important recommendations. The first recommendation, NCCN for early breast cancer, HER2 positive breast cancer, NCCN says you can use TDM1 plus minus pertuzumab, which has comparable efficacy to Trastuzumab and chemotherapy-based combination in neoadjuvant and adjuvant setting. And they believe that using TDM1 plus minus pertuzumab will have lesser toxicity, especially neutropenia, febrile neutropenia, and for that reason they will have lesser number of visits. And also, if you're not using taxanes, you will have lesser use of the steroids. Probably this study is based on a Christine study, which was published in JCO last year, where the TDM1 was combined with pertuzumab and was compared with Trastuzumab chemotherapy and pertuzumab combination, and where the TDM1 plus pertuzumab combination have shown that event-free survival events were actually more in TDM1 plus pertuzumab versus the Trastuzumab plus chemotherapy-based combination, because of possibly the local regional progression was more in TDM1 group, and but the side effects were lesser in the TDM1 group. And that's probably the basis of the recommendation of NCCN for HER2 positive breast cancer in neoadjuvant and adjuvant setting. NCCN has provided another recommendation, which is shortening the duration of Trastuzumab from 12 months to 6 months without affecting the outcomes in selected patients. And this recommendation is based on Persephone study. In Persephone study, it was a randomized controlled trial which included more than 4,000 patients, and it compared 6 months versus 12 months duration of adjuvant therapy. It was non-inferiority design study, and it included more than 4,000 patients. So the study have shown that the 6 month duration of the adjuvant use of Trastuzumab in adjuvant setting was non-inferior to 12 months duration with statistical significance. Well, there are some other studies. You can look at this, the first study, which is SOLD one. If you look at the numbers, the 5 years disease-free survival, numerically, there is no difference between 88 and 90.5%, but statistically, non-inferiority was not reached. Again, short hair, there was another study, 5 year disease-free survival, numerically very similar, but statistically, the non-inferiority was not reached. Pair 3 study, which included more than 3,000 patients, 7.5 years disease-free survival was 78.8% versus 79.6%. Again, they look numerically similar, but statistical significance was not achieved for non-inferiority. And Hellenic Oncology Research Group, they also did 6 months versus 12 months, 3 year disease-free survival numerically looks similar, but statistically non-inferiority was not reached. So based on these studies and evidence from all these studies, NCCN believe that 1 year of adjuvant trastuzumab is equivalent to 6 months adjuvant therapy with the trastuzumab adjuvant therapy is equivalent to 12 months. So based on that, I think NCCN recommendation is justifiable. We can use 6 months duration of adjuvant trastuzumab, and that will minimize the visits of the oncology patient, breast cancer patients to cancer center without affecting the outcome of these patients. NCCN has also provided the recommendation for advanced stage breast cancer during the COVID-19 pandemic. As we know that for advanced breast cancer, we have many treatment options, and typically they receive multiple lines of chemotherapy or biologic therapy, which are rarely dependent on specific treatment sequencing. So that provides flexibility to oncology physician to choose the regimens and the schedules which are reasonable to reduce the clinic visits, blood work, and development of significant side effects. And sometimes we reach time with our patients where we don't have any more options to offer to patients, or the option that we are left with have very minimal outcome. So in that kind of situation, we really need to calculate the risk versus the benefit. For example, what is the risk of disease progression if we do not give chemotherapy versus the harm or the magnitude of the harm of the COVID-19 infection? If the risk of the disease progression or the benefit from the chemotherapy or the biologic therapy is very small, then probably we need to talk to patients, take them into the confidence, and talk to them about the risk versus the benefit. And I hope that patients can understand this this problem, and they can decide, they can choose whatever they like. So I think this discussion with the patient should be transparent. For HER2 positive breast cancer, NCCN has recommended, in advanced breast cancer, NCCN has recommended to interrupt HER2 therapy in those patients who had a long-term tumor control and they had a minimal disease burden with trastuzumab-based regimens. For example, those who had more than 2 years of duration of tumor control and they had minimal disease burden. These patients, we can interrupt therapy in these kind of patients without having a significant risk of the disease progression. This study, this recommendation is based on one of the study which was published in ESMO Open 2017, which was a retrospective analysis of HER2 therapy interruption in patients responding to HER2 therapy in metastatic breast cancer. Results have shown that interruption of HER2 therapy in patients with metastatic breast cancer who had responded to therapy had a lower risk of disease progression. So therapy can be interrupted in this group of patients and can be reinitiated upon the disease progression. And NCCN has also cautioned about the use of oral targeted agents, particularly for hormone receptor positive breast cancer, for example, CDK4/6 inhibitors such as palbociclib and ribociclib, mTOR inhibitor, everolimus, PIK3CA inhibitors such as alpelisib. The use of these agents has been associated with significant adverse effects. For example, palbociclib is very well known to cause neutropenia. Ribociclib is known to cause neutropenia. So NCCN says that those patients whom we are using, for example, CDK4/6 or